Welcome. Appreciate everyone showing up. I think we can see that we probably have the only hearing going on right now because we have a packed room. But we appreciate everybody coming out and, pray for the upstate and all that they're going through. But those of us on the coast and the Midlands consider ourselves very fortunate that we didn't get the ice that they were talking about. But with that, we'll go ahead and get started on our agenda. First up, we have Center for the Rural and Primary Health Care. Dr. Harmon.
Good morning, Mr. Chairman. Good afternoon, Mr. Chairman and members of the Healthcare Subcommittee. Thanks for being here. It is my great honor to present a couple of key talking points and some members of the Center for Rural and Primary Health Care in South Carolina. Our leadership today who will be presenting our message to you is led by Dr. Kevin Bennett, who is the director, and Dr. Patricia Weatherspoon, who is the medical director of the Center for Rural and Primary Health Care. I would comment, just as a matter of introduction, Dr. Bennett has a bachelor's degree from Virginia Tech and a master's from James Madison University before he got his PhD from the University of South Carolina. So he's a respected alum and one of my good colleagues here. He's a professor of family preventive medicine at the UNC School of Medicine in Columbia, and he does serve as the director of this. Historically, he also is the immediate past president of the National Rural Healthcare Association, so he has a national presence and is very well respected. His colleague, who's my long-term friend for 20 years, is Patricia Weatherspoon. She received an undergraduate degree in Pennsylvania, a bachelor's degree in Lincoln University, and then later on a master's degree in an MD from Penn State. And she also completed a residency here at the School of Medicine in Columbia in family medicine, which happens to be my professional discipline. So Tricia and I go way back, and just this past year, I had the privilege of giving her an honorary alumni lifetime award from the School of Medicine. So she's an academic colleague of mine too, and we share that history. The Center for Rural and Primary Health Care is an integral part of the USC School of Medicine, Columbia. It's a key part of our mission to serve rural and underserved populations across the state. I myself, before I came here 2 years ago as interim dean, practiced in the rural area of Williamsburg, Georgetown, and southern Horry County. So I can attest to the value and the contributions and my love and devotion to rural and primary health care as a family medicine specialist. Through the Center for Rural and Primary Health Care and other initiatives, we're focused on increasing access to care, improving patient outcomes, and increasing the supply and the skill set of our rural workforce. This center is translating the evidence into action. We develop using evidence to develop and implement programs that change and improve the systems of care. So not only are we improving the workforce, we're improving the way we're delivering that workforce. The work is foundational to the School of Medicine, and our increased focus on rural care across all the units looks forward to supporting them in their work. Dr. Bennett's team has gained national recognition. Their expertise and models of care they are developing, and South Carolina is indeed leading the way. I'd like to turn the podium over to Dr. Kevin Bennett, and I'll be sitting back here to answer any questions, take any suggestions, and appreciate the opportunity to address. Any questions before I take a seat?
Anyone have any questions? Oh, we're good.
Well, I appreciate it, Mr. Chairman.
Look forward to Dr. Bennett.
I'll pass the baton.
Thank you, Dean Harmon. Appreciate that introduction. Thank you all for having us again. Here to talk to you all about our center and the impact we're having and the vision we have for the future of our work. As you can see here, we've been in operation since 2017, nearing our 10-year anniversary. You all have invested in us for quite a long time now, and I think we have built a wonderful center with a great infrastructure that's making substantial impact across the state. You can see our components here with healthcare delivery, connecting care to clinical from the community, workforce and training, and as well as analytics and evaluation. We want to see the impact we're making and see how things are going. Our request for this year is level funding the same as last year and no changes to the proviso. So a pretty standard approach to this year's work. Talking about our impact, you can see here from our map, we are literally all over the state. We are working with 72 programs in 241 sites across our state. Every county is represented, and we're doing work across the board. Thousands of professionals we're working with training, thousands of patients being interacted with that were lacking care before, wraparound services to thousands of residents across the state, and 235,000 approximately 235,000 miles of travel avoided last year alone. So decreasing that burden on local residents, getting care into their communities. That's what we're all about. We have these focus areas that we focus on to try to guide our work. Main tagline, a big part of our work is evidence-based programs that are innovative, and sometimes that's innovative to the state. They're evidence-based from somewhere else, and what we call R&D, rip off and duplicate. Somebody's done something good, we can do it here, let's do that. And with your investment, we're able to spread that across the state, improving access to quality healthcare, not just getting a body there, but making sure they're well-trained and of high quality. Training current and future workforce, so not only students gaining the skills, but existing professionals upgrading their skills. Connecting community to clinical. This is a big piece in rural where access is more than just putting a provider in the community. It's trying to come up with innovative ways to transport them there, to pay for it, to get, there's food deserts all over the place. Like, what are all the wraparound services that patient might need, signing them up for Medicaid and other services so that they can optimize their health. So it's more than just built infrastructure. We also analyze data. We've got a research team that looks out and sees what are we doing, what gaps are there. Team was looking this morning, there's a report out around suicide rates across the state, and certain counties are rising. So they were pulling that data, and we're trying to see what's going on there. So we're always looking at the data to see if there's something else we can do to better serve our rural residents. And then evaluating our impact. We get measures from everybody we work with to make sure that the programs are effective, that they're making an impact, and bringing value to the investment that you've given us. We'll talk a lot about maternal and child health today. I think that's a great way to see the impact we're making and the potential for the programs that we're funding. And overall, what we try to do and what we're really moving into a larger space is a systems-based approach where all these areas work together to really change how healthcare is delivered with innovative evidence-based programs. So setting up larger type systematic approaches to maternal child health, which is more than just a provider. It's more than just insurance. It's more than transportation. It's all of that working together. It's working across county lines to communicate across systems and providers and patients, and making sure that patient is centered and they get the comprehensive care that they need. That's what's been, your investment in us has really allowed us to build these larger systems that we are going to be able to spread in the near future as well. Some details as far as improving access to quality of healthcare. Our cornerstone program in here is our eye care program, which has been in existence for quite a while. We have a particular focus on maternal child health and behavioral health, and we have several programs. I think you have packets there that have a listing of our maternal child health programs. You can see the wide impact we have there. And this is just getting primary care, specialty care out into the local communities. We still have places that don't have local primary care, and we especially don't have specialty care because the way our system is set up, there's not a business case for it. So let's get a specialist out there once a month, once a week, depending on the population, so that you get local care in a place that you trust. We work a lot with other modalities, mobile health units, telehealth, other access points as well to get these services out. You can see there we have thousands of telehealth visits, patients accessing mental health. We have pediatric patients getting subspecialty care in their home communities. As far as training our current and future workforce, we're supporting existing programs and educational institutions to expand and change what they're doing so that the local residents can have better access to those resources and get those trained workforce out back into the community. And this runs the gamut from physician training, residency training, to CNA, to MSW, to CHW. We love the team-based approach to healthcare. It's very valuable for rural healthcare especially. And so we're trying to train all the gaps and fill all the needs. It's also a good economic investment when you have local residents being trained in skills that they can then get jobs and employment and continue to upgrade. We have, over 1,000 with rural-specific training, nearly 3,000 professionals being trained. We're working with USC Lancaster on a program to get CNAs trained to BSN, mostly in the evenings, so they can work during the day, get upskilled at night, and they're working with local employers, so they have a pathway to employment in the local community. Those are ideal system changes that we're able to make. I'm also very proud of our HBCU Discovery Program, which is training their students in health professions. SC State's training students to be CHWs. So not only are they getting skills and care, but they are able to engage with the community that trusts that local HBCU to get care from. So it's a community-wide model as well. Connecting community to clinical services, these are, filling that gap from is access there and can you actually obtain it, can you actually get it somehow? A lot of supportive services, some of it's CHW, social work, some other health liaison. It might be filling out paperwork. It might be setting up transportation services, some food-based services, some primary and preventive health services. And just trying to avoid having to go out of the community is key, getting patients to local medical appointments, but also getting everything else around that so that they can optimize their health. It's very difficult for someone with diabetes if they can't get the shoes they need, so they can get that wraparound social work service to get that shoe care that they need so they don't get a sore, so they don't lead to an amputation, So that's what we focus on with this, and it's a very supportive type of model. And all in all, I think what you can see is we're actually taking action. We're able to use your investment in us to actually get patient care out there, improve quality of care, improve service delivery, and get what our rural residents deserve, which is high quality access to the care that they need. I'm going to hand it off for a few minutes to my esteemed colleague, Dr. Witherspoon, and she's going to focus on some of our maternal and child health programs, and then I'll be back to wrap it up.
All right, thank you so much.
Welcome, Dr. Witherspoon.
Thank you so much. Taking action is something that I'm really passionate about. I've been before you many years. And so at the end of the day, what is the point? What is the point of you giving us this funding? What is the point of us doing on this research? And I think the point is I want to, and I imagine you as well, want to make sure that a risk factor is not where a person lives. Where you live should not dictate that you have a shorter life expectancy, that you have poorer health outcomes, that you have poor education attainment. And so with the funding you provided us, we're now putting it into action. And so one of those areas, use my little clicker here. I'm clicking. Okay, is the maternal child health. Now, maternal child health, as Dr. Harmon introduced me, I'm a family physician, and part of that training is the holistic, the entire package of the individual. So I had some obstetric training when I first started. I don't deliver babies anymore, but I've always been passionate about that. And unfortunately, it's become really personal with my own daughter recently delivering my first grandchild. And so something as simple as having a child and being pregnant should just have a nice ending. But unfortunately, with all the technology we have, her care was riddled with mishaps and missed opportunities and poor follow-through. I don't want that for anyone else. And so I'm really vested into us really making some hardcore changes in that. And the center, with the funding and the programs we have, especially when you look at the Guided Beginnings, the Guided Beginnings is an opportunity for us to go in the community, identify stakeholders, and let's pull them all together. Because every community has different assets. But we go in the community and we ask them, what is the interest that you have? What are the needs that you have? And bring those players together. And then, as opposed to that physician thinking about the patient doesn't have transportation, the patient can't afford their medication, which can be daunting in a 10 to 15-minute visit. I now, with this collaborative wraparound service, I know that I can connect with my Access Health. That person does things like finding resources. And then I can also connect with maybe they need a CHW or maybe they need a doula. And because of this program, this innovative program, this is going to be just regular for us. We want to test it, we want to prove it, we want to work on it, and then we want to spread. Guided Beginnings started out, I think we were at like 5 patients. but now we can attest to having 181 healthy babies because of that program, because physicians are not going to be kind of stifled with worrying about the needs. They know in this network, in this collaborative care, we can get patients what they need. So I'm really proud of our Guided Beginnings. And we're going to do similar things in different communities, but other communities may have different needs. As we look at our program that we have in the PD region, they decided to focus on chronic diseases, and that's fine. But what did they do? Once again, we go to the community, we get the stakeholders together, we see what they have or assets, and we bring them in a room, and we found out that transportation was a real challenge in the PD area. So we worked with the Regional Transport Association, the authority, and they are helping us get patients to their appointments. So it's about, it's what you all talk about. It's about talking to people, putting them in the room and figuring out. And so with your funding, we've been able to do that. So I'm proud of that. And then we have the MOMS program. You might have heard of that. That's the management of maternal diabetes. These individuals are pregnant and they have diabetes, which is daunting. And so that patient needs an endocrinologist, needs a primary care, needs CHW, may need a doula. And once again, we have the patient in one place, and we bring all those services around them. So it's just common sense, as my dad say, just using common sense, which he says common sense isn't always common, but that's what we're trying to do. So as we go on here, we increase the access to pediatric and specialty care, as Dr. Bennett alluded to with the eye cares program. We have children in these rural areas. It's a challenge to get the kids to maybe the big city. And so we're able to bring the specialists to them at an appointed time in their community, or maybe it's through telehealth in their schools. We're just using innovative ways to make individuals' lives better, therefore giving them access and better quality of care. And so these programs in McLeod, we have a pediatric practice that's starting there, and then also the Bradshaw Institute, which is an incredible opportunity of mental health and community resources. We understand, Dr. Bennett mentioned about the suicide rate increasing. Mental health is something we cannot bury, and the state has invested heavily into mental health. And bringing the Bradshaw from the upstate down to the Midlands is what we've been able to use some of your funding to help them out. I believe that's it, because it's what's next, Dr. Bennett. You know, I can hold on to the mic, but I'm gonna go. Thank you so very much. If you have any questions, just ask.
So, as you can see, we are working a lot with what you've given us, trying to make that impact with those groups that need it the most. What we plan to do in the future with continued investment is to continue to focus on access to quality health care, using these evidence-based models, eye care, and other modalities to get that care more local, working with existing partners in the community to expand what they're able to do and to upskill where needed. For example, talking about prenatal care and perinatal care training for family medicine physicians across the state so they can deliver that care locally. We were just talking about the Guided Beginnings, the maternal child program up in the Greenwood area. We want to expand that model. We're working with a third community up in Pickens. We have, I think, 3 or 4 more that we've picked out aspirationally we would like to work with, because I think this is a model that could really prove effective across the state to improve healthcare delivery, and it can work with other programs across the state as well. Continue to focus on maternal child health. It's one of these things where, you know, the rising tide lifts all boats. If we're able to improve systems of care for maternal and child health, it'll improve systems of care for everything else as well. Continue to expand workforce training where needed. We have upcoming programs with BSN RN programs, EMS training, which is a huge deficit, and especially in our rural communities, working with the State Office of Rural Health with that, and continuing to do other programs we're doing. And mobile health unit technical assistance. We are designated the TA Center for Mobile Health Units on a separate proviso, and we're providing support to mobile health units across the state, as well as keeping an inventory of where they are and what they do. You know, factoid is about 80% of those that we work with don't bill for services. You know, we can change that and create sustainable services and expand their services. So, and also extend our reach as far as access to primary and specialty care. So we have a lot going on. We have a lot more that we can do. And we're just thankful that you've supported rural in such a way and in such a long time. And I'm here to answer any questions that you may have.
Anyone have any questions, Dr. Bennett? So, couple questions that I have.
Of course.
Because you go back to analyzing data to better serve the state. And that's, in a rural area, that's probably about everything.
Right.
Because you're training and all to try and help fill these, what is the biggest outlier that you see in all the data that you've collected so far?
Biggest, well, I mean, recently, infant mortality report just came out. And I think Marion County, it was 24 and a half, something like that, per 100,000 deliveries.
Which is, that's the county I'm from, and that, I
Right.
remember that stat, and that
Yeah,
was,
state average is around 7.
yeah, I mean, that's
And-
three times the state average.
Right, and if you look at the top rural counties, whoa. Okay. It's advancing without me. If you look at the top probably 10 worst counties for that rate, they're all rural. And it's a myriad of issues. It's access to quality care locally, prenatal care, it's income, it's healthy habits, it's comorbidities, it's all of those things. And that's, something we're really trying to latch on to, because, gosh, that's just tragic with a country and a state with the resources we have. How do we get that out there and serve these women? Trying to use research to how do we better identify women who are at risk so we can prevent? And how do we build these systems so that everybody is caught in the net instead of falling through the gaps?
Which kind of leads me to my next study.
Sure.
The rural health dollars that are coming
The federal
in from
dollars.
the federal dollars. And that's outside of your budget requests, I
Right.
get that. But I know that there are a lot of programs or a lot of areas that you see, because that is designed for rural health. Care to comment on any ideas and suggestions you have with that money?
Yes, we have been working with Dean Harmon with a comprehensive school of medicine approach to those dollars. I believe HHS is going to put out requests for proposals as a collaborative approach. And it's a lot of what we're already doing. And I think that's a huge advantage of the investment you all have made, that we're here and we have programs ready to go, that with additional federal money, we can take and spread. Like I said, the collaborative health communities model, which is really a collaborative, community-wide, multi-county type model, can do a lot of things with additional funds. We can incorporate mobile health units into that, better incorporate telehealth, do better mental health, do better maternal child health. We can use the resources at the full university resources to provide better training and resources. We can use our other campuses around the state. We're working with HBCUs and community colleges, so we can train workforce, we can place them into these structures, deliver better care, all using money that's not even coming out of your budget.
Yeah.
And then we're here along the way, and after those funds are gone, to continue the work, continue the impact, sustainable systems that are integrated and ongoing. We can continue to nurture those ongoing, because this money is going away at some point.
Yeah, it is. So, Representative Clyburn had a question.
Thank you, Mr. Chairman. I just want to follow up on his question, and there's a lot to be done. There's no question about that, and I know you all are doing a good job. But my concern basically is not only just the rural area, but even some of the target areas in urban settings. People don't seem to know about these programs. And I just think that's a real problem. Like you mentioned, the maternity. I mean, that is just so out of kilter until it really troubles me, especially in some communities.
Right.
So I guess the real question is not only about your collaborative involvement, but how much thought are being given to really promulgating your doings in the community?
A lot. And fortunately, I have a wonderful team, a lot of whom are here with me, that go out to the communities, work with these folks. I think everybody knows across the state who we are and what we can do. We're always, I could pull up my documents of future plans. If I had $100 million, what would I do? And it would be spreading CHC, but it would be training programs, doula programs, CHW programs, some of the wraparound services. It's a comprehensive approach that's required. It is easier and more difficult to do in rural communities. It's easier in the sense that you can get everybody in the room and talk about it. And we've been able to do that with some of these CHC projects we've done. But it's more difficult because there's just fewer resources. And the patients have fewer resources. A huge problem that we always encounter is transportation. And how do we get clever with how do we work? We're talking with a regional transit authority to try to figure out some solutions. Use existing resources, leverage it, and do it in creative ways. So it is far more than just one model or this model. I think what we're trying to work towards with our systems-based approach is within each community, it's going to be a little different. Low country is definitely different than the upstate, right? And they have different populations and different needs. How do we work with that community, have them lead the change, and integrate that change into their system so that it's going to be sustainable and effective for them? And all we're doing is kind of helping and guiding and coaching and providing resources and training and other things along the way to empower those communities to thrive.
Mr. Chairman, just quickly,
Back to that when you talk about the urban, because I think about 29203.
Right.
For decades, they've had a problem. I mean, that's right around Prisma, downtown Columbia, for the highest amputations for diabetic patients. I mean, that's an urban problem. That is nationwide. We are the highest amputations in this urban area. So why is that? And we sit around in a room and trying to figure out, but I think we need to break down silos and really try to pull people together. But I think about back in the 60s when my mom started walking. She said, JFK said, get out and walk. It's almost as if we need a voice to speak to the people.
That's right.
What is it that you need to do to make your health better? And she started walking. So it seems, placating, but that, having the right voice to talk to the people that you deserve to have a better health, you need to be engaged with your health. And that's something I've been always hoping and advocating for our patients, to advocate for themselves, to see that they can have better. But so I just couldn't miss that opportunity.
Mr. Chairman, since you're up there, one quick question for you.
Yes, sir.
What was Dr. Harmon, what was he talking about this lifetime award thing? What's that about?
Yes.
Okay, but thank you.
Honorary.
You can answer that later for me.
Honorary alumni.
Thank you.
But it was an incredible award that they bestowed upon me. Did not anticipate it at all, but my good friend felt that my work deserved it, and I'm appreciative of that.
Thank you, Mr. Chairman. I don't
Thank
want
you.
the chairman to get after me.
Okay, Representative Hosey.
Yes.
Thank you, Mr. Chairman. Good afternoon again. When you stated over 12,000 miles of travel to medical appointments were saved for families in Bamberg and Barnwell counties, what actually you mean by that?
So it's preventing them from having to go to further out communities to get care, to other providers outside their communities, whether through telehealth appointments, through virtual visits, through receiving care with a mobile unit at their local provider. So it's a variety of approaches to try to keep care in that local community. So now that instead of having to travel from Bamberg to Columbia or Sumter, they can get it there at their primary care office.
Okay. Let me take you on a 15-second journey. And that journey is saying that you just don't know unless you experience rural South Carolina. You just don't know it. You don't know it on what's happening to people who right now under electricity they don't have from the storm and that kind of thing until you experience it. We don't have hospitals in Barnwell. We have an aid station, okay?
Right.
And population, people are growing and coming through. So your services, as Representative Clyburn mentioned, how do we get this information to the local people that we have these services available? Some people are just going without because they don't know.
Right.
Is anywhere we can help, community organizations or whatever can help get this word out? Let's see, can we get it done? And the last question you have a concern is home health care. Is that same as your organization?
We don't currently work with any home health care organizations. But, you know, if we work with a Self-Regional or a McLeod or folks like that, they obviously partner with home health. And, yeah, that's long-term care and home health care is an interesting trend to see that most of that seems to be consolidating into urban centers. And local home health agencies in rural communities are decreasing. And that's just part of the consolidation market-based structure of healthcare in our current century. And we're at the mercy of those urban for-profit centers to make sure the home health aides get out to those rural communities, and that's a challenge. And, you know, a lot of it comes down to, you know, and we have a very big philosophy on working with the communities, the Bambergs, the Barnwells, you know, et cetera, to get to know what their needs are and to listen to them on what their needs are. And we kind of depend on them to spread the word. You know, last thing you want to do is me from USC come down to Barnwell and say, hey, I'm here to help. Let me tell you what to do. That's not going to work. They're going to shut down immediately. But if the local family medicine doc tells them, if they have a pharmacist, they can tell them, the pastor can tell them. That's where we try to engage the community, and that wraparound connecting the community to clinical care comes into play of how do we utilize the folks there that want to do good and tell their folks, you know, hey, this is a good thing to do. Back in the COVID days, we worked with churches to get vaccination on Sunday morning, testing sites, those sorts of things. It's a very effective model in a lot of communities. I think Alonti, who I think is here, always says, if grandma doesn't endorse it, nobody endorses it. You know, so how do you get grandma involved and spread the word that way? And it's just working with the partners that are already there and trusted partners that are there and empowering them and engaging them and giving them the resources to go and affect their community more effectively.
Thank you.
Of course.
Okay, any other questions? Thank y'all.
All right.
Appreciate y'all coming as always. Great information. Appreciate y'all spending some time with me in the all-season.
Of course.
Help me understand your agency. Well, I mean, rural healthcare is a tremendous need in our state, and appreciate what y'all do
Yep.
for that. And Dr. Harmon, hopefully we can get interim removed off of your name on here between next time we meet. So, all right, thank y'all.
Thank you for your time.
We're going to take a quick recess. We're having some audio issues on the broadcast, so we're going to take a quick recess, hopefully only a couple minutes, and then we'll move on to the next agenda item. Thank y'all. Okay, everyone, I'm not sure we got it fixed yet or not, but Representative Rutherford was online. We're not sure if he's on or not, but we'll go ahead and get started. Next up, we had Department of Vocational Rehabilitation, Commissioner Johnson. Welcome.
Good afternoon, Mr. Chairman and members of the subcommittee. Okay, let me get this. Okay, I'll just. Thank you for this opportunity to present our budget request. I do have a couple of, that's not me, hold on. There we go. I have a couple of my executive leadership team members in the audience today. We do have Sabrina Walker. She's our Director of Grants and Funds Management. She keeps us fiscally responsible. We have Miss Yvonne Young. She's our Director of the Disability Determination Services Unit. And we have Mr. Wesley Stokes. He's our Facilities Manager and Project Director. I'd like to begin with giving just a brief overview of our agency. We were established here in South Carolina in 1927. We've been doing a lot of research on our agency, getting prepared for our 100-year anniversary coming up next year. And our agency is the designated state agency to provide employment services for people with disabilities in South Carolina. Our mission is to prepare and assist eligible South Carolinians with disabilities to achieve and maintain competitive employment. We work with over 135 different types of disabling conditions, and our services are all individualized. So two people with the same disabling condition will not necessarily receive the same services. It depends on how that disability impacts that individual and what their career objectives are. You'll see in our mission statement the word eligible. We are an eligibility agency and not an entitlement agency. So what that means is we have eligibility criteria that must be met in order for someone with a disability to participate in our services. The criteria standards are that they have to have a documented physical or mental disability. That disability must substantially impact their ability to obtain, maintain, or keep employment. They have to be able to benefit from the services that our agency provides in order to go to work, and they have to desire to work. So if they meet those criteria, they are eligible for VR services and can participate in our program. During last state fiscal year, we served almost 24,000 individuals with disabilities throughout our 31 offices throughout the state. We did see a rise in referrals last year of 6.9% over the previous year. We assisted 3,937 individuals with disabilities to either obtain new employment or maintain their current employment and successfully exit our program. Our calculations show that for every consumer that exits benefits and goes into employment, they end up paying $3.40 in taxes for every dollar that was spent on the cost of their rehabilitation. And to date, we have had 1,500 successfully employed consumers with disabilities exit our program, and currently we have over 2,200 consumers that are still actively participating but are gainfully employed, and they should successfully exit our program by the end of this state fiscal year. When consumers are referred to us for services, over half of them report having no income at all, and after they complete our program and receive vocational rehabilitation services, they typically go to work working over 30 hours a week. Our consumers have the opportunity to develop employment skills in our 27 job readiness training centers that we have across the state. We partner with over 200 businesses, and they outsource several hundred product lines to our vocational rehabilitation training centers. Our consumers report to these centers, and they learn job skills to help them advance in employment, and most oftentimes are hired with some of these same businesses that provide us the training product in our centers. We remain committed to serving youth. Over 40% of the consumers that we serve are between the ages of 16 and 24 and involved in some type of educational program, whether that be high school or college. And we also oversee the Disability Determination Services Department for our state. Despite some very significant staffing challenges last year, our DDS department did exceed their established goals regarding initial claims, reconsideration claims, continuing disability review claims, and the other category, which includes hearings. All those goals were exceeded by the DDS last year. Okay, I will now move on to our requests. We do have 3 requests. They are all capital projects, and they are all included in year 2 of the CPIP. Our first request is to replace the roof on our Muscular Development Center. This building is located on our state office campus in West Columbia, and it's a specialized facility that's designed to enhance the physical capabilities of individuals with disabilities as we support them toward their journey of employment. This center offers customized fitness training. It offers physical therapy. We have a pool in this building where our consumers participate in aquatics therapy, and we also provide nutritional counseling and weight management. These services are a part of our comprehensive evaluation process where our consumers come for a 28-day evaluation to assess their strengths, their opportunities for employment, and also make rehabilitation adjustments for any barriers to employment they may have. And the focus is to increase their physical resilience so that they will be able to work preferably 40 hours a week, but part-time hours are also acceptable. This facility was built in 1986. The last time the roof was replaced was in 2004. Despite several efforts over the past year to repair and patch the roof on this facility, we continue to have issues with leaks. We're at a point now where water is coming from the roof through the ceiling, causing interior damage to the building. The total cost to repair this roof is estimated at $450,000. We are requesting 25% of that cost, $112,500, and we would use federal funding for the remaining 75%, which is $337,500, pending the necessary federal approvals. Our next request is for our state office building, also in West Columbia. This building serves as the headquarters for all of the agency's administrative and programmatic operations. This facility is in need of new variable air volume boxes and pneumatic controls. This building was constructed in 1983 and still has the original VAV boxes, which are now beginning to fail due to their age. And unfortunately, the parts that we need to repair these boxes are no longer available. The building's HVAC system was replaced in December of 2022, and by replacing these failing VAV boxes and adding new digital controls, we will be providing increased energy efficiency for the facility. The total cost of this project is $590,000. We are requesting 25% of that cost in state funds, which is $147,500, and the remaining $442,500 would be paid with federal funds pending the necessary federal approval. And our final request is for funds to repave the parking lot at our Beaufort area office. The Beaufort office serves both Beaufort and Jasper counties and is one of our most productive areas in terms of job skills training. Our Job Readiness Training Center at this location provides skill training to approximately 20 consumers with disabilities each day. The Beaufort area office team there has 36 active training contracts with businesses in the local community, and consumers who train at this facility normally leave out of that facility into employment averaging a starting wage of $13.80 in their community. The parking lot at this location has deteriorated but beyond normal repairs. The total cost to repave it would be $675,000. We are asking for 25% of that cost in state funds, which would be $168,750. And again, we would pay for the remaining 75% with federal funds in the amount of $506,250. We would also use our federal grant award funds to cover the cost of maintenance and care for the pavement. And we will add exterior lighting to this project to enhance the safety and security of the area office there. So in total, we are requesting $428,750 in state funds. And that concludes my presentation. I'll be happy to answer any questions.
Okay, thank you. Anyone have any questions?
One quick question. Mr.
All right,
Chairman.
Representative Clyburn.
Thank you, Mr. Chairman. The eligibility, who determines, how is that determined? I understand, I know doctors are involved, but do you have a commission or something that's involved to give the impairment rating or the disability rating?
No, sir, we just need some type of medical documentation stating that you have the disabling condition that you state. Now, we do have another process called expedited eligibility, whereas our counselors are trained, if they can visually see a disabling condition, then they can go ahead and make the individual eligible for services. For example, the group that presented before me was talking about amputations. Well, if someone comes into our office with an amputation, that's a visible disability that we can see, so we can go ahead and make them eligible for services.
Right, and listen, it's no question y'all doing a great job, but and you're asking for 428. It's hard to believe that you get $3+ on investment for every dollar you spend for rehabilitation.
Well, the state would get it in taxes once the individual gets off of state benefits and enters the workforce, and they begin to earn income and have to pay taxes,
Right.
so that would go to the state.
Yeah, it's amazing how that is measured, and not all of that's over a certain period of time.
Yes, sir.
Right. Thank you, Mr. Chair.
Kind of in the same breath, it's my understanding there's a tremendous backlog of claims within your agency.
Are you talking about disability
Disability,
determination
yeah,
services?
disability determination
Yes,
services.
sir. There is.
What can we do to speed up that process? Because there are people waiting on that determination. And
I am so glad you asked that question,
Yeah.
and I get to bring one of my executive team members up. They always come and never get to speak.
No, that
So
is
I'm gonna
great, because
invite-
we need to figure out what we can do to help.
Absolutely,
that.
and we appreciate that, but I will step aside and let Yvonne answer that question.
Hey, good afternoon. How are you all doing? Yes, we have had a
And your
tremendous.
name was, I'm sorry.
I'm sorry, Yvonne Young.
Okay,
Yes,
welcome,
I'm
Ms.
the
Young.
director here at Disability Determination Services. We have had a tremendous backlog. It has been really a perfect storm since COVID. I know everybody blames COVID for everything, but it really is. That sort of is what started a lot of this during that time period. We also had a complete overhaul of the system that we use for determining, case processing. So that was an adjustment that had to be done with the staff. We also had staff loss. Folks sort of during COVID and being able to telework and things like that found other remote jobs. They wanted to be at home 24/7, understandably so in certain situations. But that did create quite the backlog, because with less staff and folks continuing to, of course, apply for disability, that left a huge backlog, particularly in our initial backlog. Back in May of 2024, we had over 40,000 cases that were waiting to be processed, and just have not had the staff to get that caught up, unfortunately. One of the issues is that SSA is who determines if we have hiring authority to bring on new staff. That has been inconsistent as far as the hiring. Last year, there were only 200 hires authorized for DDS across the nation, and our state got 8 of them. So that's a huge, when you lose 25 people in a fiscal year and you only get 8, you're not really, gaining anything. So that's the biggest issue is our staffing. Now, last year, we did bring our pending initials down tremendously. We're down to less than 6,000 at this point. Folks were waiting for 2 years for an initial. Now they're waiting through, it's 3 months before they get assigned to an examiner. When you lose examiners, it's a 2-year process to get them fully trained to be productive in being able to process those claims fully. Of course, it's difficult with everything required for training an examiner. They get trained. Some of them, I guess, when we've asked them, when they've left during that training process or have stayed around, they compare it to a master's level program because of the information that they're learning. They're learning all the medical terminology, and we work with medical consultants who help in rating those claims, but we're doing as much as we humanly can to get these cases processed without burning out the current staff we have. So the biggest thing would just be staffing. SSA did assist us with multiple sites, either from other states who didn't have the influx of cases that we were receiving, as well as federal sites with that last year. So that did help us bring that initial backlog down. We do still have a considerable backlog of reconsideration cases, but that is less than 10,000 now as well. So while we do still have quite a backlog, it has come down considerably, and considering we haven't been able to hire on the folks to process those cases, we are doing everything we possibly can. Everybody who's been trained in processing cases, whether they're a quality analyst or a supervisor, gets cases. It's really an all hands on deck process that we're working with now, but we are talking to SSA regularly, trying to figure out different ways that we can get assistance. We actually have a visit with them tomorrow. They have a team coming down to assess sort of what are our business processes, what's working, what might they be able to assist with more. So we're doing everything we possibly can. So any questions about any of that?
No, thank you.
Sure.
Staffing issue is, I don't care what business you're in, it's staffing issue, especially since COVID.
Yes.
But we seem to be coming out of that. Seems like you're making some progress, but
Yes.
Again, when compared to other states, we are behind other states in the conversations with SSA or get through the governor's office, reaching out to the federal delegation, whatever we need to do.
Right.
We need to get that done because we need to speed up that process because,
Yes.
You're admitting we got problems and I'm not sure how we do that, but I think we need to get all hands on deck to see what we can to help resolve that issue.
Yes, definitely. I would agree. If there's anything, some of the different things as far as, examiners, when they leave, different things, of course, the telework is always a challenging thing to compete with. We've lost folks to VA. We've lost folks to Social Security because their federal examiners who do the same thing ours do get paid twice as much because they're federal employees, of course. So it's just some competition, but certainly, anything that can be done about the hiring issue being more of a consistent battle with that has been challenging because when you lose an examiner who's been here for 20 years to the VA, you're not just going to be able to hire somebody who has no clue what DDS is, but they have the education and ability to learn it. They're not going to do that for 2 years. So that's a whole caseload of an average of 150 cases that's not being worked. And when we lose someone, those cases get dispersed to others, and that's more cases not coming out of the staging backlog.
So you're talking about a 2-year training program to
Yes.
get somebody up.
For
and then
a-
you're losing them. What is the difference in the pay? You talk master's degree between what you can pay versus losing someone to VA, which I assume is why you lose people. Either they get bored after 2 years or either you train them and somebody, takes those from you, what is that incentive for them to make that move?
Well, for instance, the base salary for our examiners here in the state is now $39,000, and that averages more around 65 or 70 for federal examiners at the same rate.
It's enough motivation.
Yeah.
So,
And they're remote. I mean, prior to them all being brought back in, that's another thing we're battling as well. We do have some, legal rep type communities that are not, I'm sorry, agencies that are 100% telework, and they love getting disability folks because disability folks know everything about disability. So when you're talking about a legal rep representing someone for that, then, those are the types of things that we struggle with.
yeah, and I understand you struggle.
Yeah,
Hopefully
yeah.
we can get it resolved, because that
Yes.
is what I hear, most
Right.
about that is the delay and the backlog that you have there.
Yes.
All right, any other questions? All right, thank y'all.
Thank you so much.
Okay, next, Commissioner of the Blind, Commissioner Graham.
Good afternoon.
Good afternoon.
Mr. Chairman.
Thank you for being-
members. How are y'all doing? Cold enough for you?
I'm afraid it's only going to get colder as the week goes, so.
Yes. Okay, well, we will go ahead and get started. And first, I would like to announce or get a few members of my team to introduce themselves, if that's okay with y'all. They're in the audience. So let's just start. Ken, you want to stand up? I'm making y'all stand up. I wanted y'all to meet them because I can't do what I do without them. They're so important to our agency. So, very lucky to have them. Next, I would like to take a few minutes to highlight our mission and briefly explain our agency. We have such an important mission, which is to provide quality, individualized vocational rehabilitation services, independent living services, and prevention of blindness services to blind and low-vision consumers that leads to competitive employment and social and/or economic independence. And actually, breaking down our mission statement is a really good way to explain our agency in sort of a nutshell. Our largest program, our vocational rehabilitation program, is primarily focused on helping our consumers find or maintain employment. We provide counseling and guidance, educational opportunities, vocational training, and assistive technology, all in preparation for employment. Part of the VR program also involves a residential component that's located in Columbia, and the services are very individualized and are also focused on helping people get ready for employment. Individuals stay on our campus Monday through Friday, and they may be in training, or they're typically in training for several months. In addition, our business enterprise program is also focused on employment. Our 16-week training program helps prepare individuals to become entrepreneurs. The licensed vendors currently operate 56 vending or food service facilities statewide, including 10 dining facilities at Fort Jackson, where our agency has a nearly $70 million contract with the Army. And I'll explain more about that in just a minute. Next slide. Our mission also focuses on independence. In children's services, which is 100% state-funded, we help provide children with vision loss from ages 3 to 12 with assistive technology they can use not only in school but at home. This helps them build confidence and learn independence. Next, our mission focuses on prevention services, which is also 100% state-funded and is an amazing program that provides sight-saving services. For example, we pay for cataract surgeries, retinal detachment repairs, and other services for individuals who meet financial need requirements. We also offer older blind services to individuals age 55 and older with severe vision loss. Many of them attend our low vision clinics that are offered around the state. We provide them with assessment so that we can recommend low vision devices and assistive technology. These services help them remain independent and in their own homes longer. And so next, we're going to talk a little bit about program growth. Over the past year, we continued to expand the number of vending stands which feature micro markets across the state. Micro markets offer a variety of food and machines with an accessible kiosk that allows the blind vendor to better operate their stand and provides easy checkout for the customers. Y'all have may visited some of the micro markets on the state capitol grounds, maybe? Since opening the micro market at the South Carolina Department of Education in '24, we've opened 2 more at the State Capitol Complex for a total of 4 micro markets on the State House grounds and a total of 8 statewide. Also, we set up the first Smart Market at the Veterans Administration Regional Office in Columbia in October of '25. As you can see in the picture, a Smart Market allows customers to swipe their card, open the door, and make their selections. Weight sensors track what products are added or removed and charge only for the items removed. So we plan to open an additional 6 Smart Markets later this year, including 2 at the Navy Administration buildings at the Joint Base in Charleston. Also, we continue to manage the nearly $70 million dining contract at Fort Jackson. It's one of the largest military contracts under the Randolph-Shepard vending program in the country. The blind licensed vendors employ more than 900 people to operate the 10 dining facilities at Fort Jackson, where the soldiers are served an average of 25,000 meals daily. Our role is to manage the contract, ensuring all the contract is in compliance and all the requirements are being met. Blind vendors also operate vending at all of the 28 rest stops and welcome centers throughout the state, as well as the Savannah River site, for a total of 56 stands. Our agency is responsible for purchasing, installing, and maintaining vending equipment at these 56 stands for a total of over 600 machines statewide. And when it's no longer cost-effective to maintain the vending equipment, it's recycled. Our agency utilizes the funds from recycling to help support the Older Blind program. However, this only amounts to between $5,000 to $8,000 per year. But as you can see, we strive to be fiscally responsible. We put this money from recycling to the Older Blind program as it continues to grow as more individuals 55 and older seek services for vision issues related to aging. More individuals need services to assist with macular degeneration, glaucoma, cataracts, diabetic retinopathy. While the number of consumers in all of our programs has grown over the past 4 years, you can see on the chart that there's actually been a significant increase in the Older Blind program. Actually, South Carolina serves more individuals in our Older Blind program than a lot of other states, as South Carolina is one of the top states where retirees are moving because of our climate, and it's tax-friendly, right? We went from serving 661 consumers in SFY '22 to serving 1,720 in SFY '25. That's a 160% increase. In SFY '25, we held 78 low vision clinics around the state where assistive technology devices are provided. As a matter of fact, last year we spent well over $400,000 on AT devices and training. Next, in our Prevention of Blindness program, where we assist individuals to receive sight-saving or sight-improving procedures or surgeries, we've had a 66% increase in consumers just over the past year. And over the past 4 years, the number has increased by 390%. And as we serve more consumers, the amount we have spent on surgeries and treatment has also increased, of course. For example, in SFY '23, we spent $82,832 on surgeries and treatments. In SFY '25, we spent $206,784. So, and of course, all of this is leading to our request. So our first priority, as I mentioned, due to the 160% increase in older blind consumers, the 390% increase in prevention of blindness consumers, and the increase we projected for SFY '26, we're asking for $553,301 in recurring funds to help us meet the needs of consumers who can benefit from these critical services. Priority 2. As an agency, we're encouraged to utilize information technology shared services from the Department of Administration, which provides critical networking and hardware and software support throughout our agency. As you're probably aware, the cost for shared services has recently increased by 32%. Therefore, we're asking for $113,008 to cover this increased expense. Priority 3. We're requesting to add additional spending authority to be able to utilize the actual amount of funds received from federal grant awards to cover salaries and fringe operating and case services. This request is for $7,053,880 in spending authority. Priority 4, as the contract with Fort Jackson continues to increase, we need to increase our authorization to be able to meet the obligation of the contract, so we're requesting an additional $26 million in spending authority. These funds, just to explain the process and how this works, the funds are received by the State Treasurer's Office from the Army, earning interest for the state, passed to SCCB, and then distributed to the blind license vendors operating the dining facilities at Fort Jackson. And I just want to make it clear, our agency does not utilize any of the funds. Priority 5, we're also asking for non-recurring funds in the amount of $361,450 so that the Association for the Blind and Visually Impaired can fill gaps in service provision for us. Unfortunately, under our federal VR grant, we cannot serve adults who do not express a desire to go to work because the funding is to support services for employment. And in older blind, we can't serve individuals under 55. These individuals under 55 often need assistance with adjustment to blindness training and independent living training in order to gain the confidence and skills needed to even hopefully eventually consider employment. So again, we desperately need their help to assist with these services. And next, we are requesting 2 new provisos this year. The first proviso would allow us to carry forward any unused balance of the prior year state matching funds and any unused balance from our state-funded programs to use in the current fiscal year. The second proviso would allow us to retain our indirect cost reimbursement to assist with the match requirement for federal funds, maintenance of effort for the VR grant, and support training center and residential facility maintenance. As I mentioned earlier, similar to colleges and universities, we provide on-campus training with residential services. And next is just a summary of our request. And finally, we have 2 amazing success stories in your packet. I would encourage you to take a look at those. And lastly, I just thank you for your continued support and your time, and I'll be glad to answer any questions that you have.
Okay, thank you. Anyone have any questions, Ms. Graham? Representative Newton.
The prevention numbers, the increase, which was, I think, 390% in like 4 years. Is that, do you think, population increase, or do you think part of that's just people are realizing they can get these services more, and so you're attracting more clientele?
That's a good question. I would definitely in older blind is due to the increase in population as people age, people are moving to our state, as I mentioned. In the prevention program, I think we're probably doing a better job with outreach. We've established a lot of partnerships and relationships with ophthalmologists and optometrists, so we're just seeing a big increase in referrals.
I mean, I hate to say, but I think that's a great number to see go up, because I agree with you. I don't think that's population as much as just more people aware of the services, which I think is a good thing.
Right. And I used to say that's one of my favorite, or my favorite program at the agency, because just the amazing, things that we can provide, help people with to save their sight and help improve their sight. But we do amazing things in all of our programs. So.
Representative Clyburn.
Thank you, Mr. Chairman. On the vending operation, what kind of income and how is that put into place?
income for the blind licensed vendors,
Yes.
it varies. It's all over the board, but I can tell you the average income has definitely gone up as our BEP director has done a great job at kind of what we refer to as cleaning up some of the stands. Because you might have a vending stop that only had a couple of machines that really wasn't making a really good living for the blind licensed vendor. So a lot of stands have been consolidated. But you have the people at Fort Jackson make about $1 million a year. But then some of the stands make, probably in the 20s. Ryan, I'm going to ask you, what's the good average right now? Is it in the 30s? Have we got up that high?
So one of the things, like she said, that we've worked on,
We could talk all day about the BEP program. Go ahead.
Good morning, Ryan Skinner. One of the things we focused on is the annual average income and the annual medians. So we're working to drive that up like she described. From 24 to 25, we had an increase of 20,000 in the annual average income. The median went up by 7,000. That annual average without the Fort Jackson incomes is around 47,000 right now.
So we've worked on it hard. It's increased substantially because all the hard work his team has done.
So you don't have any problems placing those operations? Have there been any repercussion from any of the proprietors?
I wouldn't say that we've never had complaints with I wouldn't say that we've never had complaints from some of the people we hold contracts with, but we work really hard to train the blind license vendors that are in our program to make sure they understand the importance of customer service, making sure all the machines are stocked properly, all the products are not expired. So we've really made major improvements in that program, I would say, over the past 3 years.
All right, Mr. Chairman, I don't have no real problem with the request, but, there's so many problems out there when it comes to young people with dental care and vision. So what are we doing about these youngsters, 4 to 6, 4 to 7? Are there any tracking, and can you just tell me a little bit about where we are on that and maybe what we need to do to improve what we have?
Absolutely. We start serving individuals as early as 3 years old. And we actually have our pre-employment transition program that focuses on individuals aged 13 to 21. So there's a lot of services that we can provide that group of individuals who are getting ready for employment. All the services are focused on employment and helping them get there eventually.
Right, I'm concerned about, the 3, 4, 5, 6 years old who have low vision. It is so prevalent, and I just kind of wonder, do you address that?
One of the biggest things we do for the children, I would refer to them before they get to that age 13, is we provide them with assistive technology devices because the schools have the devices, but when they can't take the devices home, they can't use them in the summer. So we can fill in those gaps and we can provide those AT devices for them to use at home as well. Plus, some of them are involved in certain programs that we offer around the state as well.
I have some other questions, but that's okay for right now.
Okay.
Thank you, Mr. Chairman.
I'll be glad to answer any questions.
Okay, thank you. I know we've had some other issues that we've talked about, and hopefully we can circle back on that. And
Okay.
we're making progress in that area, but, thank you and your team for allowing Tisha and I to come out and visit what y'all do and see y'all's office and what you provide firsthand. It really helps you understand the great services that y'all provide, and I want to thank y'all for hosting us and letting us come out to see y'all.
Well, I want to thank you for coming out, and I do think it really helps to come out and see what we do. So I'm going to extend the invitation to any of y'all that would love to come out. We'll be glad to have you.
Okay?
You test my eyes too? Good.
Yeah.
Okay.
We
Thank
can
you.
get you in our low vision clinic. Yeah.
Oh, my goodness.
All right, thank you.
Okay, thank y'all. Have a good day.
Okay, next we have Children's Advocacy up. Mrs. Bodner.
Yes.
Hey.
How are you? First off, just to introduce myself, I'm Margaret Bodman, and I'm currently serving as the interim state director and state child advocate of the Department of Children's Advocacy. If all goes well, hopefully by the end of February, I will be confirmed and being able to continue to serve in this capacity. The previous director, Amanda Whittle, is now Judge Amanda Whittle, and the work that the DCA has done since it's been created in 2019 has always been incredibly impressive to me. But seeing it from the inside and coming in and watching the staff in particular and how passionate and skilled they are has been incredibly impressive to me, and I'm very blessed to be there. With me here today is Ladera Depew, who is our Chief of Staff, and she took the reins as the interim director between Amanda Whittle leaving and my appointment. Tina Hardy, who's our General Counsel, Jasmine Depew, who's our Accounting and Fiscal Manager. Somewhere in the audience is, there we go, Tom Kaminer, who is our Budget Director. And then we also have an extern, a third-year law student who's with us this semester and observing. The responsibilities that the DCA has is the breadth and the depth of our responsibilities is incredible. So we are responsible for ensuring timely, safe, and effective services for children in our state, promoting a broad vision of reform. So based upon the complaints and the investigations that we do, hopefully compile data and bring that to the State House to recommend improvements. We do educate the public about our responsibilities and the responsibilities of 9 child-serving agencies, serving on many task forces and committees, maintaining the child abuse protocol. And then in addition to our staff of about 240, really so much of our work is done by volunteers. So our guardian ad litem volunteers and our foster care review board volunteers. So you can see from those numbers, they are really the bulk of the work that the DCA does, and we're incredibly grateful to them. In the DCA, we have 4 separate divisions. 3 of them existed prior to the creation of the DCA, and then when we were created, those divisions joined the DCA. And then the System Improvement Division is a newly created division. So there were 0 employees in 2019 when the agency began, and now the System Improvement Division has about 27 positions in that division. So our guardian ad litem program is the volunteers are appointed in abuse and neglect cases. They are not paid. They are wholly volunteer and representing children in those cases. Our foster care review division provides support for the state board as well as the local boards. And our Heart Gallery. So we are accountability for kids in the foster care system and making sure that they are moving timely and effectively towards permanence, whatever that permanent situation may be for that child. And then our System Improvement Division is made up of 2 separate units. We have an investigations unit that is more of a forward-facing unit. And then we have our critical incident division. And the critical incident division receives notifications of fatalities or near fatalities from the 9 child-serving agencies that we sort of oversee and respond to investigations. So they are mandated to report to us critical incidents. And then the other one, the complaints, can come from anyone in the state where a concern comes about a child not receiving services or receiving inadequate services from one of those agencies. So that could be anywhere from a professional to just a citizen who notices maybe a neighbor or family member or friend. This is just a summary of our requests that I'm going to go over with you today. So starting with our system improvement division is, as I said, we have 2 separate units, and this graph sort of shows the rapid increase in the number of critical incident notifications we've received from the 9 child serving agencies. So actually, even prior to the 2022 on the graph is in 2020, we only received 30 notifications. 2021, we were at 77. 2022, 417. 23, 1,519 notifications of critical incidents. 2024 was 2,894 notifications. And then in 2025, it was at 3,022 notifications of critical incidents. So we may not investigate all of those, but those notifications are coming to us exponentially more. This year, to date of the fiscal year, we're at 2,405 critical incident notifications. So we are on par to match or surpass the critical notifications that we've received before. In our forward-facing unit, the investigations unit, we have maintained sort of an average between 2,900 and 3,500 complaints, and those are sort of coming through our hotline, and those are either investigated or there may be a warm handoff to another agency to assist in that with that family. But with that is our caseloads for the staff are above what they need to be to really thoroughly investigate these cases. And so we are requesting 5 FTEs for the system improvement, so for both of those units, to try to be able to respond to the critical incidents and to the complaint notifications. In addition to the investigatory responsibilities that they have is they also respond to court hearings, maybe for those individual children. So just to date, to give you an idea, is the division has done about 36 hours of community events, 10 hours of presentations to other agencies, and about 88 site visits. So this is walking through facilities, placements, speaking to the youth at those facilities. This does not include individual youth visits for investigations. These are just general site visits to see how the general facility is, how the youth are. So that's in addition to our investigations. And we've gone to about 11 court hearings. So those are maybe at the request of a judge for us to come and speak on behalf of the investigation and the child and our recommendations. Our guardian ad litem program, over the years, unfortunately, our volunteer pool has significantly decreased. Pre-COVID, we were at about 2,000 volunteers. We are currently down to just under 900 volunteers. So that means that our staff is having to take on these cases and be appointed as guardian ad litems. And that can be in addition to supervising the volunteers and their caseloads and making sure that the volunteers have the resources and supervision and knowledge that they need to be able to adequately advocate on the best interest of that child. So they have to see the child at least once a month, report writing, and in independent investigations that they're responsible for doing. So we desperately need some more FTEs as we go out and try to recruit more volunteers. And every county is a different picture and why we don't have those volunteers and how we need to get those. But we've got to fill that gap. Our foster care review board, they're asking for an FTE, legal assistant for our general counsel. Our responsibilities, regulatory responsibilities and legal advocacy has increased over the years. This was not a general counsel position even a couple of years ago, and so their responsibilities have increased, and we need to get them some support that they need in order to do that regulatory and legal advocacy. Our Continuum of Care division, we are in a terrible situation with our Continuum of Care division. They have been in existence for about 40 years. It started in 1983, I believe, with a proviso from the legislators to start a pilot program to see if we can serve children with severe emotional and behavioral needs. At the end of that pilot program, it was successful and resulted in legislation to make them a permanent state agency. And so since that time, they have been serving children in our state with severe emotional and behavioral needs in various capacities. And they have moved through agencies, ultimately landing with the Department of Children's Advocacy in 2019. In about 2018, I believe, the Continuum of Care contracted with DHHS to provide services under a Medicaid waiver program to serve these children in order to keep them out of facilities and to be able to keep them at home with their families. And so providing wraparound services, care coordination, vocational, educational supports and guidance for the family. This Medicaid waiver allowed the Continuum of Care to be able to bill Medicaid at a sustainable rate. In addition, they have grown over the years, and in, I believe, 2018, we also, I say we, the royal we, I wasn't there at the time, found out that we had been getting under-reimbursed for, prior to the waiver program, we had been getting under-reimbursed for the Medicaid services. And it resulted in about a $6 million, between $6 and $7 million repayment to the Continuum of Care for those underbilled services. So the Continuum has essentially sort of been living off of this carry forward money and the Medicaid waiver program that was sustainable. Prior to my arrival, there were discussions and decision was made to terminate that Medicaid waiver program. So with the movement of youth or families from classic Medicaid to MCOs, really the clientele dried up for the Continuum of Care. So we don't have that work anymore for the Continuum of Care. When I first created this budget, our financial outlook was that at the end of this fiscal year, we would end up with about $300,000 in carry forward funds, and then, would not be sustainable going into the next year. We condensed offices, we condensed the use of cars, really reduced our expenses. As individuals have left the Continuum of Care, we've not replaced their positions. And now we're in a situation where it looks at the end of this fiscal year, we'll actually have about $1.5 million in our carry forward funds, and our expenses have gone down from almost 5 million to, we've reduced it about $1 million. The issue is obviously the work. We've been in substantial conversations with DSS about possible work to do in partnership with them, working on a couple of things, but the last one was youth that are leaving DJJ and are at risk of entering DSS care. So either the family doesn't want the child to return home, or the child doesn't want to return home. So now possibly this child's going to go into DSS care. So we would be doing family engagement meetings, facilitating family engagement meetings to keep that child out of care. Essentially is DSS doesn't have the funding, the state appropriations to pay us for this work, and we're going to run out of money if we don't get our appropriations that we have gotten previously, and if we can't have continued access to that carry forward funds. I've also reached out and trying to explore potential work that may come out of the ad hoc committee on juvenile justice reform. I believe that we have a skilled staff that is ready to do necessary and important work that we have right now in our state in trying to keep our youth out of DJJ facilities, out of DSS care, and frankly, out of our psychiatric hospitals. So they are skilled and they are ready to work. It is asking that we still be able to have our carry forward funds and that we've saved all this money, and also to continue getting our appropriations. DSS is ready to partner, with us to do this work. It's finding the funding to be able to do that work and keep the staff. The other issue we have obviously is timing, is we're going to run out of this money at the end of the fiscal year, and I'm looking at potentially a reduction in force of that staff if I don't know that I'm going to have that funding. There are also other conversations. I'm willing to talk to anybody and everybody that has an idea for work and partner with them with this very skilled and motivated staff. They have been doing a lot of other work. They've been filling in as guardian ad litems. They have been working with the foster care review division and assisting them with their knowledge on kids that have these needs that they're used to working with, and a number of other projects that they've really still been hard at work on. So that's really just our current situation. Is I'm no longer asking for additional money. I am asking just that we still have the appropriations that we've been given in prior years, and that we're allowed to still have that carry forward funds. Sorry, that was a little lengthy, but.
No, but thank you for explaining. That was very.
Yeah, thank you. Guardian ad litem, our best interest request is really divided into two separate requests. We have 1.5 million in general funds that we are asking for to cover increase just inflationary costs. We've increased our staff by about 25 over the past 5 years. So just with all the additional expenses and costs, we are asking for that money. In addition, we are asking for the 3.4 million in increase in other funds spend authority so that it more closely aligns with the revenue that the Guardian ad litem program has. If we don't get the 1.5 million, we are going to probably be asking for incremental increases, because we have been digging into the carry forward funds significantly. And at this rate, we are looking at depleting those carry forward funds. So we're going to try to close the gap on our expenses and our income, but we do need this incremental help to try to close that gap. Regarding the $3.4 million in other funds spend authority, as you can see, the difference between sort of what our generated revenue is and our authorized spending under that revenue. So we're just asking that it more closely aligns with what our revenue is. IT operations, IT is getting more expensive, and we just need to close the gap in our expenses for IT. For all the FTEs that we've requested, for each FTE that's approved, we would just need one-time operating expenses to onboard that staff. The continuum of care has a longstanding proviso, 35.1, that transfers $400,000 from Office of Mental Health to us. I don't expect that anything's going to happen to that proviso, but then in the event, we would ask for that $400,000 to make up for the proviso money. Our Guardian Ad Litem and Foster Care Review Board request regarding salaries to really just close the pay disparity that resulted from the statewide pay matrix and 2% salary increases. We now have employees that have been there for a very long time and are making essentially the same as new staff that are being onboarded under the new payment matrix. $750,000 on behalf of the South Carolina Children's Trust. Sarah Knox is here with Children's Trust and wants to be able to address that along with unrelated budget requests. So I'm going to leave that with her, but suffice it to say that our work needs to be on both ends of abuse and neglect, is the prevention work as well as the response to it and accountability. So we appreciate your support for the Children's Trust. And then, I'm sorry. Okay. And then finally, for the South Carolina Network of Children's Advocacy Centers, is present here is Tom Knapp, who's the president and CEO of the network, and would be happy to answer any questions that you have regarding this request. From my experience as a prosecutor working child abuse cases, I have personal experience and knowledge of the vital work that our CACs do and the support that the network provides these children's advocacy centers. The number of children that come through our CACs and get incredible support, important forensic interviews in a best practice and trauma-informed manner, and all of the training that they do to our multidisciplinary professionals that have to respond to these cases and investigate these cases so that the right decision is made. Their work is just incredibly vital, so I would ask that you support our network of CACs. That is it. Anybody
Okay.
has questions?
Thank you for your presentation. I can't imagine some of the stories, and it's just hard to believe that, children have to get the treatment or get treated the way they do.
Yeah.
Does anyone have any questions before we move on? Question, why the increase in notifications over such a short time period? I mean, to go to the hundreds to over 3,000, is there more, is the opportunity to place a notification easier, or I mean, what caused that?
I think it's two things. One, I think it is learning about the notifications and their mandatory obligation to report it to us. So I think at first it was hard to get that information out there, and we had to, Judge Amanda Whittle had to cover a lot of land to get the word out. Honestly, I think the more important thing is that we have built great relationships with these agencies. And they understand that we're not here to get them. We're not here to catch them at something. We're not here to call them out. We are honestly here to support them and to assist them to make any improvements that are necessary. And so I think it's their trust in us and our fairness in looking at the situations and being able to give honest feedback as to how we think a case might be improved, or saying, you know, great job, there wasn't anything that you could have done to avoid this situation, and thanks for bringing it to our attention, because we need the data in order to be able to make reform. So I really think it's the relationships we've built with these agencies.
The other stat that caught my attention was the guardian ad litems dropping from over 2,000 down to 900. What can we do to, I mean, what is the cause of that? And I guess your proposal can try and get us going back in the right direction. But I mean, with the population surging that it is, but yet that's dropping, somewhat concerning.
Yeah, it absolutely is. We have staff that are dedicated to recruitment, and they are placed throughout the state. So they're not here, you know, in Columbia. They are placed throughout the regions in our state, and they're actively engaged in recruiting activities. You know, I think one of it was just the result of COVID, as so many things happen as a result of that. And so numbers immediately dropped off. They didn't want to come to court. They didn't want to be going into people's homes. And then trying to rebuild from that, it takes a special person who can listen to that information, look at the case file and the photos and the information of what happened to this child. And, you know, the time constraints. Also, sometimes a child, you know, they may be in Horry County, but their child was placed in Anderson. And so they have to go visit that child at least once a month. And so that's a lot on a volunteer, which that's, you know, not the normal, but things like that, you know, not everything is happening right there in their county. So it's going to require more time and effort. So I think we just need to all work together to get the word out that it is important work, although tough, it is important work. And just working in each individual county as to what's the word or the message that we need that will work for that community to get them involved.
Okay, thank you.
Thank
Tough
you very
shoes to
much.
follow
Yeah.
and judge, yeah, so.
I know. Thank you.
Okay, so now we've got 4 other presentations, moving away from state agencies. Children's Trust, Sarah Knox. You're not Sarah.
I am not Sarah. Good afternoon, Chairman Hewitt and members of the committee. Thank you for this opportunity to speak with you today. I am Sue Williams, the director of the Children's Trust, sometimes known as the Children's Trust Fund. Children's Trust is a quasi-government entity. We were created in 1984 by the General Assembly as an eleemosynary corporation, meaning public and private. At the time of our creation, the General Assembly chose to fund us through the voluntary income tax checkoff, which today generates about $40,000 annually. As I mentioned, we're a semi-state agency, but we are governed by a board of directors appointed by the governor, and we are accountable to both the executive and legislative branches. Today, I'm here to speak in support of a request included in the governor's budget for $5 million in recurring funds to flow through DPH to Children's Trust. These funds would be used to expand voluntary home visiting programs statewide as a proven strategy to address South Carolina's maternal and infant health crisis. You all are familiar with the troubling statistics around maternal health in our state. The one I want to highlight today is this. DPH estimates that 80% of maternal deaths in South Carolina are preventable. That statistic is alarming, but is also hopeful. It tells us that with the right interventions, delivered early and consistently, can save lives. Prevention is exactly what Children's Trust does, and we know that home visiting works. 95% of caregivers reported always using safe sleep practices with their infants in our home visiting programs. Among all caregivers who did not have a high school degree or equivalent at enrollment, 38% achieved their high school diploma or GED during the reporting year. But more importantly, one of the programs we support in Orangeburg County has seen 0 maternal deaths among their participating families since inception. 0. Currently, Children's Trust administers South Carolina's federal home visiting grant. Through that funding, we have already built the infrastructure, accountability systems, and on-the-ground expertise needed to deploy home visiting services effectively across the state. However, the federal funding alone only allows us to reach less than 10% of eligible families, and the need is far greater. State investments would allow us to scale what is already working, not to create something new, but to expand proven programs using existing infrastructure. With this funding, we can reach more mothers in more counties and provide the consistent support that we know improves maternal health outcomes and gives babies a stronger start. In closing, Children's Trust is prepared to be a responsible steward of state dollars. We have decades of experience, strong oversight, and a clear track record of prevention success. With this investment, South Carolina has the opportunity to move the needle on maternal health in a meaningful, measurable way. Thank you for your time and consideration. I'm happy to answer any questions.
Thank you. Any questions? Okay. And yeah, you did note the governor did include it in his budget.
We
so-
did, yes, and this would be in lieu of the $750,000 in Margaret's budget.
Okay.
Although if you want to give us that too, that's fine.
So
But we will use that we are required by the federal grant to get a match that is a 3-to-1 match. That was the $750,000, but with the $5 million in recurring, we would be able to make that match every year.
Okay.
Right.
All right. Thank you. Okay, next, Power in Changing, Jessica McMore. Oh, excuse me. I misread. Ms. White, yes.
Hello. Thank you for having me here, and good afternoon, Chairman Hewitt and members of the committee. Again, thank you for the opportunity to be here, for me to be here today. I know the subcommittee hears some of the most important funding requests when it involves our state matters of health and well-being, and I appreciate your time and attention. My name is Ayanna White, and I am the founder of Power in Changing. For more than 10 years, our nonprofit has worked with families across South Carolina, distributing distributing over 1.7 million diapers to parents raising young children since our inception. Power in Changing began from lived experience. I'm a single mom, and I understand what it meant to work hard and do everything right and still come up short. Not because of poor choices, but because of the gaps in the system meant to help. Over the years, that experience has shaped our work and taught us something important. Diaper need isn't a charity issue. It is a public health issue, it is a child well-being issue, and it is a workforce issue. Diaper need means not having enough clean diapers to keep a child healthy, dry, and able to attend childcare each day. As the materials that I've sent over, but I do have some here, show 1 in 2 families in our state experience diaper need. Diapers and wipes are not allowable expenses under any other program such as SNAP, WIC, or Medicaid due to federal program rules and regulations. Yet most child care centers, providers require families to supply them in order for a child to attend. When families don't have enough diapers, the impact is immediate. Babies experience higher rates of diaper rash, infections. Parents miss work or school because they cannot meet child care requirements. Stress builds, health and well-being suffer, and families begin to slide. Not from lack of effort, but because a basic need is unmet. We see this every single day. Demand for our services continue to grow. In the past year alone, Power in Changing distributed more than 465,000 diapers across both urban and rural communities. Families tell us that something as simple as a diaper access helps them stay working, keep their children healthier, and avoid crises that are far more costly to address later. And most importantly, being able to provide diapers to a family in need reminds us that we're all human with the same basic needs. That's why I'm here today. This proposal is not about creating a new program. It's about strengthening what already exists and seeking to partner with a state agency to expand our reach and operational footprint. We are requesting $750,000 over a 24-month period to address diaper need as a preventative health intervention. This approach allows support to reach families where there already are, using infrastructure the state has in place. Our current footprint is strong in the Midlands, but with your support and the investment from the General Assembly, we could extend access across additional regions of the state, from upstate counties like Pickens and Cherokee, through the Midlands and PD, and into coastal communities such as Georgetown County. Under the model, a state agency would serve as a connection point for families, while Power and Changing would coordinate procurement, distribution, and outcome reporting. This investment would support thousands of children and their families during the earliest and most critical years of development, helping families stay healthier, sanitary, stable, and connected to work and childcare. This is a low-cost, high-impact prevention strategy. Diapers cost cents. Emergency room visits cost thousands. And the stress caused by unmet basic needs can lead to lasting scars. This proposal builds on systems the state already relies on, offers measurable outcomes to inform future decisions, and helps families stay stable before they reach crisis. At Power and Changing, we've seen what happens when gaps are closed early and thoughtfully. This partnership gives South Carolina the opportunity to do exactly with care, responsibility, compassion, and families at the center. Thank you for your time and continued commitment to South Carolina families. And I'm open to any questions.
Thank you. Anyone have any questions? Representative Newton.
Thank you, Mr. Chairman. Ms. White, as someone who has a 1-year-old and buy diapers, it's a lot more expensive than people think it is. Yes. How would this program work? I mean, you mentioned that there would be a state agency you work in to get the diapers out. What's that like? What would be the agency? How would you get it into the communities of the state and all that?
So we have a great relationship with Department of Public Health as well as the Department of Social Services. Being that they're already implanted in certain counties, especially in counties in the upstate or more rural areas, we would disseminate the diapers there to them, have a person on staff to get those items to families in need, and also we would look for that state agency to help identify some of the families that are more at risk. Especially with them being low income or facing a hardship.
Yeah, I was going to suggest too, if it's funded, working with OB offices, yes. Especially in rural areas, because typically they know the need because they see the patient.
Exactly.
And would be a good use of that resource. But thank you, very, very good request, because you're right. I've always been shocked that the feds don't allow WIC or food stamps to be used for this, and it's never made any sense to me either, so
exactly.
Thank you.
It's a stopgap. What we're trying to fulfill is a gap in the system, so, yes.
Okay, yes, Representative Clyburn.
Mr. Chairman, just quickly, I just want to say that, I think this is a very important program, simply because, to me, it reaches what we call the underserved.
Yes.
And a lot of times, much that has been discussed here today and been discussed in past years, they sort of don't reach what we call the underserved. And so I'm glad, how long has the program been in existence?
10 years.
10 years.
So I'm a single mom. I face diaper need.
Yeah, I understand that, but it's been 10 years. It's been pretty successful.
Yes.
Right.
Each year we grew.
And so you're requesting like $750 now. In the past, what have you survived on?
Private grants and foundational support and donors.
And it normally came about around a total of what?
So in the past 10 years, we have received probably over $1 million in just funding, and that's throughout the 10 years. We did receive a federal grant, we were a sub-grantee from the Triple DRP program. So we did receive some funding as a pilot position, but
Any matching is concerned with your federal funds, it's just straight funds.
yeah. And since then, the program has, it's being reviewed currently.
I think it's a great program. Thanks.
Thank you. Thank you.
Thank you, Mr. Chairman.
Okay, thank you. Thank you for your presentation.
Thank you.
Okay, moving on, Community Action Partners.
Good afternoon,
Good afternoon.
Chairman, and thanks, and good afternoon to all of you. It is indeed a pleasure and an opportunity to present and introduce to you the Community Action Network, which we are an innovative and evidence-based program that provide a plethora of services using a holistic approach. And my model for that, we serve those in need before the cradle and to the grave. And I used to say to the grave to one of my team members said, well, Ms. McMoore, they're not dead yet. So we serve them before the cradle and before the grave through all various types of programs. I'm here representing as the CEO of the South Carolina Association of Community Action Partnerships, which represents the Community Action Network, where we serve a plethora of services before the cradle, beginning with our pregnant moms, beginning with our Diaper Dash program that you mentioned. We're #1 in the country for the Diaper Dash program, and there's a video where the Office of Community Service came down to shoot a video to show the collaborative approach in delivering its services across the state. And then from before the cradle, we have our Head Start program, where we get children ready for school, and then our youth leadership to deal with the dropout rates and to work with the school systems. And then when life happens, we have crisis intervention program to help us stabilize families as they go through illness, as they're sick, or whatever reason. We assist in payment first to get them stabilized with the rent payments, as well as through getting them set up in an apartment. We work with the homeless. We work with all populations and all sectors of the community. And we also work with our weatherization and housing programs to ensure energy efficiency. So we work with a plethora of services and programs to increase self-sufficiency. Are you aware that South Carolina ranks 10 in the top 10 states with the highest poverty level? So that's what we've been doing for over 60 years, fighting the war on poverty, increasing self-sufficiency. The role of the community action, we play a very pivotal role, vital role in improving the lives of those in need. We can only serve so many of those that are in poverty. Even with the living wage of $52,000, they're still struggling for financial success. So we only are serving 22% of those living in poverty. The remaining continue to struggle without adequate support and resources. And also, part of our team, I'd like to introduce Ms. Karen Brackett-Browning. She is the Vice President of our South Carolina CAP Directors Association, and Mr. James Paisley, who is the President of our CAP Directors Association. But we have an urgent need for support. Despite leveraging resources, and we partner with all sectors of the community. We do community needs assessment every year to ensure that we are fulfilling the needs of the community, but the urgency for effective intervention is clear when we're only reaching 22% of those in need. And at this time, I'd like to have Mr. Paisley as well as Ms. Brackett to share with you, in addition to their role in our network, they're also executive directors of local community action agencies across the state.
Thank you. Good afternoon. I am the executive director for Waccamaw EOC, which includes Williamsburg, Horry, and Georgetown County. Representative Hewitt is in my district. I wanted to talk to you really about the mission of Community Action Agency and how it's going to roll into our ask. We are really that agency that's been around trying to find and identify and alleviate or ameliorate the root causes of poverty. As you know, we've just celebrated our 60th year of operation, continuous operation throughout the country. I want to talk a little bit about our accountability. You know, we're one of the only nonprofit congressional programs that's funded. In other words, we are in the Congressional Act for OCS. We are accountable. We are a federal program where our resources come in, and we're audited several times a year. Matter of fact, in our agency, we have a room just set aside for the auditors and the monitors. I can boast that for the past 17 years, we've had a clean audit with no findings, no suggestions, or whatever. So we are an accountable agency. Our governance of our program, we have a local board of directors. We have a tripartite board. It's made up of the public, private sector, and an elected representative of the poor who represents our agencies. So we have the stability in our agencies. We also are strategically located throughout the state of South Carolina. We have bricks and mortar capacity staff in every county in the state of South Carolina. We're there already in order to provide services. During the pandemic, we were a source of information, staging to help our health departments provide shots for the people of South Carolina. So we've been there. We know what's going on in the community. And what we're coming here asking for an investment to help us leverage what we're already doing. So we talk about what is going to be the ROI, the return on investment. We're talking about the assistance that you would invest with us that would help us leverage the services we're already providing. For example, our weatherization program. Many of you may be familiar with weatherization. It's a program that allows us to rehabilitate the existing housing stock that's been dilapidated. People are living in it. They're just getting by. They have tremendous heating, cooling costs. They have pests and all these kind of things because of the condition of the home. Our weatherization program is a federally funded program by the Department of Energy, but we cannot work on homes if they're not up to a certain condition. Now, for example, Horry County last year gave us a $500,000 grant to assist us with the weatherization program. What did we do with that money? That money allowed us to bring those homes that would not pass for the DOE weatherization funds. They weren't sturdy enough for us to put in the investment. So on average, the average investment was $10,000 in the home. We put in another $12,000. We were able to bring those homes up to standard living conditions that were reduced the energy consumption, made these homes livable. People didn't have to move out. We were able to restore blighted communities. All this is a result of that investment. So that's how we leverage. We took the county's money from CDBG, and we were able to do the things that we couldn't do with the federal dollars to bring it up to standards so that we could provide the assistance. So that's one form of leveraging that we were able to do with those discretionary dollars that we couldn't do with the federal dollars. We also have some other challenges that we could address with the benefit cliff. You all probably have heard that terminology before, the benefit cliff. Many people stay where they are in their condition of poverty because they're afraid to move to the next step, because if they do, they're going to lose their benefits. So they don't feel that moving to the next step in their progress or bridge out of poverty would be worth it because of what they would lose in benefits. Ms. Brackett Browning is going to address some conditions like that their program has addressed.
Thank you. I promise you I'll be brief. I'm Karen Brackett Browning. I'm the Executive Director, CEO of Carolina Community Action, serving Chester, Lancaster, Fairfield, Union, and York County, South Carolina. And as Mr. Paisley has aforementioned, the benefits cliff, that's a a situation where we've had individuals who could not pay their light bills. They couldn't pay their utility bills, but they were over income. Their income exceeded the eligibility criteria based upon the grant funding. So one of the past innovative initiatives that we've had is with Lockhart Power Company that's down in Union County, South Carolina. And Lockhart gave us funds to help those individuals that were over the income guidelines for the grant, but were still within what you would declare as economically disadvantaged. And so we were able to help those individuals with that partnership to maintain their utilities in their home. Many of them were in the situation because there was a reduction in force at their jobs, and a lot of this was during the COVID, so a lot of them could not find work during that period of time. So that is why our ask of these funds are going to be so important as well, because it will still help us to serve individuals who are still economically disadvantaged but are over the income necessarily to receive grant funds. And I just wanted to also mention that we look at them on a continuum. We try to help them in community action to move them from a critical state to a thriving state. Every program that we've ever operated or will operate has that basic premise in mind to help individuals to achieve self-sufficiency and financial independence. So with that, I think Ms. McMoore is going to close.
The last thing I would say is that, for your information, since we've been sitting here, every program that has come to this table in some way, shape, or form, Community Action partners with, in some way, shape, or form. So I just wanted to let you know we are a partner and collaborative in the state.
So at this time, we are asking that the committee consider a crucial investment of economic mobility of those who are really struggling, financially insecure. There are 1.4 million people living below the livable wage here in South Carolina, and that livable wage is $52,222. Our demand for services have increased. Our ask is $8 million. I know some of you say, wow, $8 million. But this is based on the census data of the number of low-income individuals in each county. So we have a breakdown that you will provide that shows, based on the census data of those that are living in poverty, based on the federal poverty guidelines, those range based on that population data. And it could, so we have it broken down by the various counties based on the census data. And you can see exactly how much money each of the 46 counties will be getting. The Community Action Network make a strong impact in the community. For each dollar of CSBG funds that we spend, we leverage $19.20. For each dollar, $19.20. Of federal, state, local, private, and even volunteers that work. Who do we serve? We serve over 161,767 people with low incomes who are living in 67,706 families. So that's 67,706 families that we're serving every year. And the demand has increased, but we're only reaching 22% of those in poverty. Some of the examples that the people we serve are 22,121 people who lacked health care, 23,417 people who are reporting having a disability, 16,949 senior citizens, 59,643 children living in poverty, and 1,163 veterans and active military persons. And there's been a surge in demand from services within the last 3 years, when we was 121,000 back in 21, now we're up to nearly 200,000, and our request is coming in every day. And the living wage is the one that may be $1 over the income guidelines that we can't serve. This investment would help us meet those needs for those that are financially struggling. And thank you, and we look forward to you investing a critical and crucial investment to economic mobility. Thank you. Are there any questions?
Thank you. Any questions? Representative Clyburn.
Thank you, Mr. Chairman. Mr. Chairman, let me just say, I think this is the first time that community action have been before us, have been before me that I can remember. But it's just a great organization. They've had auditors, internal auditors, external auditors, and it's been watched very closely by the federal government. And they've been very, very efficient, especially for those in underserved areas, in poverty areas. I was brought up in a poverty area myself, and just been above it in the past few years. So I understand where they're coming from, and I don't think we can overhear someone or a group who really put emphasis on trying to uplift people from poverty. And so I commend the group. It's a good thing you from the chairman's, he's one of your constituents. That might help, but I appreciate what the organization does. Community Action, Head Start, has just been great for underserved areas. Thank you, Mr. Chairman.
Thank you. Representative Hosey.
Thank you, Mr. Chairman. I'd just like to piggyback on Representative Clyburn, that it is a very, very needed and council, Community Action Council, something like the CDC in our area. But I want to say that it's being chaired by some people I know. Those three persons there, and Paisley, I know them well. To be honorable people who do honorable services for the people of South Carolina, especially in the rural areas. So I hope that we give great consideration in the requests that we receive from them, because it's very, very well needed. Thank you very much.
Thank you, Representative Hosey. Just a point of clarification. The $12 million, that's not tied to a match with federal government. That's just a straight request from us.
Yes.
Okay. Thank y'all.
Thank you.
Okay. To wrap up our agenda, Pace Center for Girls, Heather Smith.
Good afternoon, Mr. Chairman and members of the committee. Thank you for your time this afternoon. I come before you today on behalf of Pace Center for Girls. We are requesting recurring $700,000 this year, and I wanted to let everyone know Pace Center for Girls, as a reminder, serves in the Dillon, Marion, Florence County area, and we serve typically 100 girls every 9 months. Our girls come to us as referrals from DJJ, from the court systems, and from the school systems, and also through self-referral with the families or them. We help the girls with socioeconomic issues that are going on, with mental health issues that are going on, truancy issues, and of course, DJJ issues. DJJ has sent many girls to us to keep them out of the system, and I am happy to report that we have a 98.7% success rate on all the girls that we have helped over the last 4.5 years. This funding that we are requesting will allow us to continue services with the 5 schools that we have MOUs with, and it will help us with our 2 licensed therapists, our executive director, and the committee that we utilize within the communities to help build the community out better and keep our program going stronger. And I am going to step and see if there are any questions.
Any questions? 98% success rate, that's,
98.7%.
excuse me, 98.7.
Sorry,
So,
had to throw
that's
that
right.
in. But I did want to let you know we are also in the states of Florida and Georgia, and we're just making our way back up here and hope to stay here.
Okay, thank you.
Mr. Chairman.
Hold on a second, Representative Clyburn.
Mr. Chairman, I would like to know, brother, what kind of collaboration you with other organizations in the state that really benefit girls, and I know that helps so much with mortality rate and with some of the other kinds of related
I am
illness.
grateful that you asked that question, Representative Clyburn, because if you look in the state, there are not any entities such as PACE, because we focus on girls. We are the only entity in the state that actually takes the girls and focuses on them. However, in the past, we have worked with HHS and DJJ and the court systems and, of course, the schools, because we do go into the schools and help where the schools do not have a resource, the resources there for licensed therapists to help those girls get through the crises that they are going through and keep them in school. And I'm happy that our graduation rates are actually up in those areas.
Mr. Chairman, this is something I probably, that you and I would talk about. I will come to you with it. But, and you don't have to answer this, but it just seemed like to me it's just inextricable from with what we're trying to do about infant mortality and education and poverty. It's just, and I don't know what to say about it other than there ought to be some kind of cohesiveness and collaboration. Maybe you or her may want to address that.
Well, thank you for pointing that out. I mean, that's one thing we always encourage with all the agencies that were in here, and several times a day we heard working with other agencies. Collaboration is key on everything that we do, and whether it's rural, I mean, we have a lot of different state agencies working on a lot of the same things, but they've got to work together, and if they do, then we get better results. So I appreciate you pointing that out. Okay,
Thank you very much.
Okay, that concludes our agenda today, so unless there's any other items y'all would like to bring before the committee, we'll stand adjourned.